and agencies, representatives of development partners, religious institutions, cultural institutions, NGOs, and our partners from AHF, the media fraternity, all the youth here, ladies and gentlemen. I'm delighted to be here today and to deliver a keynote on the theme Achieving Zero New HIV Infections Among Youth in Uganda by 2030. I'm even more delighted that we have in this room most of the people we need to work with to ensure that we attain the ultimate goal of ending HIV by 2030. The goal as it looks, the goal looks insurmountable, but is attainable. When we talk about HIV and AIDS in Uganda, every one of us here, those online and everywhere, have seen the impact it can have on children, on youth, on adults, on families, and on communities, and the entire country at large. It's not limited to our boundaries. It is a real global issue. Therefore, identifying one day to discuss the role of the youth in ending HIV transmission and infections as part of the International Youth Week is highly commendable. Ladies and gentlemen, attainment of our Vision 2040 is highly premised on a healthy, educated, and highly skilled workforce. Today's children and youth, who make up 75% of our national population, are key constituents in the attainment of this vision. To put it plainly, they will be the adults who will experience firsthand the socio-economic transformation we are currently working so hard for. HIV and AIDS, therefore, threatens their existence, their resilience, their productivity, their future, their relationships, and their lives. To improve population health and safety, the current National Development Plan 3 has identified reducing the burden of communicable diseases with a focus on high-burden diseases such as malaria, HIV/AIDS, TB, and hepatitis. Our target is reducing AIDS-related mortality from 5% in 2020 to 2% by 2025. As policymakers, we are alive to the fact that the laws and policies are a means to an end, but not an end in themselves. Uganda's HIV/AIDS journey has been consistent with a mixture of progressive policies and guidelines as well as transformative evidence-based practices. Improvements in HIV and AIDS data management and utilization, investment in research, development, and implementation of quality care and treatment regimes, among others, have produced commendable results for us over the years. What we have not curtailed, though, is the increasing number of young people getting infected with HIV on a daily basis, as already indicated. According to the Uganda AIDS Commission, over 15,000 newly infected people every year are aged between 15 and 25 years, with only 47.3% of all young people testing for HIV. This number may even be higher. We must address the youth cascade in all HIV and AIDS prevention, care, and treatment programs. We have to reach all youth, whether in school or out of school, at all costs. We have to ensure that we support them with the right information and accessible commodities to stay healthy or to stay on treatment for the rest of their lives. Through our programs, we have been effective in reaching youth in schools, tertiary institutions, and workplaces. Programs targeting out-of-school youth, who are currently in millions, are very few, scattered, and unsustainable. They are seemingly being left out. The life skills and health education framework for out-of-school youth under discussion today is a great opportunity to reach them. The framework is aware of the unique experiences and challenges they face and seeks to build and strengthen their knowledge and skills to adapt healthier lifestyles and live HIV-free lives. We also want to integrate this information in all our youth empowerment programs to minimize risks associated with rising urbanization, increased exposure to social media, perceived change in income levels, education attainment, and overall social status. For us to achieve the success we want, we must build stronger partnerships with everyone here, with all ministries, departments, and agencies, development partners, civil society organizations, and private sector. We must work with all religious denominations and cultural institutions to end harmful cultural and social norms that increase risks to HIV infection among our young people. To all the youth in this audience today, HIV is preventable. Your body is your temple, and you have to take care of it. Abstain, be faithful, or consistently and correctly use a condom if you must. Love yourself and test yourself. And no matter how much you think you love someone, no one is worth your life. HIV is not a death sentence, but is a life sentence. Just in case you get it, there is something to do about it. But the best is to avoid getting it. As I conclude, I thank all of you for making time to attend this dialogue. Your presence and participation here is true testament to what we all aspire, an HIV-free generation. I strongly appreciate the partnership we have with all of you. In a special way, I would like to thank the members of Parliament, the committees of Gender, Committee of Health, and that of HIV/AIDS, as well as the Aid Healthcare Foundation for working with us in organizing this dialogue. I highly recommend that we make it an annual dialogue because we need to review progress of implementing the framework and reduction in HIV and AIDS infection among the young people in Uganda. I thank you for God and my country.
Thank you. Thank you very much, Mr. Permanent Secretary, for that powerful statement. HIV is not a death sentence, but it is a life sentence. I'll take that home with me. Permit me to recognize Hajj Aruma Muhammad, the Secretary General of Uganda Muslim Supreme Council. Thank you for being with us. Allow me also recognize Reverend Agaba Andrew, Director for Household and Community Transformation, Province of Church of Uganda, representing the Provincial Secretary Church of Uganda. You are welcome, Reverend Agaba. At the Ministry of Gender, we believe that it will take all of us to manage the problems that we face every day. We need the cultural and religious leaders to walk this journey with us. So when I see you around here, I really thank God that you are here with us, and we shall walk the journey together. Allow me now to invite Ms. Nakusara, who is going to present to us life skills and health education, the untapped potential to reducing HIV infection among out-of-school youth. We are here to emphasize the out-of-school youth because I think we have done a lot for the in-school. So we want these hard-to-reach people, and they are the majority, by the way. Many children in Uganda, they are not at school. They are out there in the community. How do we reach them with interventions that can save their lives? Sarah Naku works with UNAIDS as community mobilization and networking advisor. She has served UNAIDS for 1 decade, that's 10 years. And before joining UNAIDS, she worked with UNDP as a fellow with Center for Disease Control, and also worked with strategic communication organizations. At UNAIDS, she's the focal point person for civil society organizations, religious and cultural organizations, parliament, private sector, refugees, human rights, and gender. We wouldn't have got a better person to speak to us about life skills and health education, the untapped potential for reducing HIV infections among our out-of-school youth than Naku, who is here with us. May you join me in welcoming Naku to come and speak to us. Please clap until she reaches here. Yes. You're welcome.
Thank you, Commissioner Mondo. Thank you. Good morning. Once again, I'm Sarah Naku, the person he was speaking to. I'm glad to stand before you to make a presentation on what one of our co-sponsors would have spoken to, that is UNFPA. I'm here with my other co-sponsor, Barbara Sire from UNICEF. She's there. She's just at the back. And we were talking, and I said, Barbara, this is UNFPA's job, but as a secretariat for the 11 UN agencies, let me take it on. And I do the job that UNFPA would have done. But they are with us in spirit. In fact, when this call came in, they simply asked, where is the link for this? UNAIDS is a secretariat, so it coordinates 11 UN agencies, and anything that comes up we share with all those 11 UN agencies. And then we inform them that we'll be doing this on your behalf so that we don't contradict with them, and they also don't assume we are taking over their roles. I have a presentation that I will speak to. As I said earlier, my role is to focus on life skills and health education for the out of school, not in school. We are so much nowadays into in school, but we are also acknowledging that it's very key and important focus on the out of school, because Uganda's population, we can move to the next, Uganda's population is heavily densed on the adolescent and young people, that is below 30 years of age, it's at 74%, while 10 to 29 years of age, which is our contemporary age, mainly in terms of new HIV infections, teenage pregnancy, and sexual gender-based violence cases, we have approximately 20 million of our population. And we are aware that that 10 to 29, most of them are actually out of school. We are, as I said earlier, we are focusing on in-school. So we've explored the data regarding those that are in school, and the numbers are actually very skewed. So majority of the target group that we are looking out for to end AIDS by 2030, they're actually out of school. I also want to re-echo, we are, as UNAIDS and our 11 co-sponsors, we are promising the world to end AIDS, not HIV. So by 2030, we would have ended AIDS. Those are the diseases predisposing, the diseases that accompany us if one is diagnosed to be with HIV, but not HIV. We can only end HIV if we have the vaccine. We move to the next presentation, please. New infections stand as they are, 78.3% among our adolescent and young people. Globally, Uganda is the 5th in the entire world with the highest new infections. The first one is South Africa, followed by India, Nigeria, Tanzania, then Uganda follows. Then from Uganda, Kenya follows Uganda, then Zambia, and then Zimbabwe. So if we are to address the epidemic, those are the prime countries that we need to concentrate on in terms of reducing the 1.5 million new infections globally in the entire world. Uganda attributes 52,000 new infections to that 1.5 million infections. We have 38 million people living with HIV globally, and the 1.4 is what Uganda contributes to. So when we look at the infections still among the adolescent and young people, we still realize that every, like if you find 5 people, if you are to count and say how, if we are to see the new contracts for HIV, new infections, I'm looking at the infection at that level, every 5 you find, 4 will be the adolescent and the young people. That's how bad the situation is. Please go back to the previous presentation. Then when it comes to issues to do with childbearing, 1 in every 4 you find, they will be young between the age of 15 to 19 years of age. Like if you go to an ANC center and, or you went to any health care center and you looked at those that have given birth and you looked at the age range of those particular people that have given birth, 1 in every 4 that you find at that healthcare center will be between the age of 15 to 19. So it means these are young people. They are adolescent, they are young, and some of them are even not ready to give birth at that time. We register over 250. The data I presented there is slightly a little bit old before we launched the report in July. We registered over 250 new infections per week among the adolescent and young people, so we are not doing well as a country. Yet at the same time, we know that teenage pregnancy cases have also increased at a tune of, we were at 25% during COVID-19, but we've come down slightly due to school. When children went back to school, then we registered a slight decrease at around 21%. But we also know when it comes to sexual abuse, mainly for those adolescent and young people, mainly 18 to 24 years of age, every 3 that you find that have been sexually abused, 1 at least will be between that particular age group. And then also in every 6 men that you find that have been sexually abused, we tend to assume men are non-sexually abused, but they are, only that they keep quiet at times. Every 1 in those 6 that have been abused have actually also been sexually abused. So we are aware and we know that we are ideally not managing well, even among the sociocultural practices that we take on as a country, like FGM. Over 1.4% of the women and girls have experienced FGM. We know it's more among the 45 and above, and we tend to say, no, this has decreased. It has, but it's a culture norm. So as you stop FGM from Uganda, then the team crosses over to Nairobi, and then they practice from that side and then come back, because it's a culture issue. And culture changes with time, and it takes really a long time, a long period of time. We can move to the next one. And we are also aware when it comes to knowledge levels, we are doing extremely badly now. we launched what we call ESA commitments, which focus more on, globally, it was comprehensive sexuality education. For Uganda, we adopted sexuality education. Now, for the out of school, we've adopted life skills and health education. While for the in-school, it is sexuality education. The comprehensive was removed to remove what we feel does not abide by the customs, beliefs, and the culture of the country. So we concentrated on what we felt was very key and critical for us. But an assessment was done looking at the Eastern South African region, specifically to see among all countries that committed to sexuality education or life skills and health education, what is the performance in terms of adopting that kind of knowledge among the adolescent and young people, most especially so that they are better decision makers, they can be in position to inspire themselves, they can be in position to innovate, they can be in position to transform economically. And Uganda, we implemented at a tune of 31%. The average in some countries, not countries, I would say in the whole of Africa, was 67%. Eastern South African region was the worst. I think for East Africa, we're the worst again. So Uganda were at a tune at 31%, while Tanzania, I think it had 20%. Kenya had 48%. I'm looking at now the Eastern region rather, East Africa. Then Rwanda had 55%. No wonder, when you look at those percentages, it clearly explains why new infections are higher in particular countries, why Uganda is not registering low new HIV infections among the adolescent and young people compared to Rwanda. Rwanda that implemented a tune at 55%. They are not even among the first 10 priorities to focus on in terms of reducing new infections. So it means they are progressing. While for Uganda, we are always close to Tanzania. I think we really resemble a lot in many things. Uganda, Tanzania, Kenya, we are always there, whether with new infections, when it comes to sexuality education, teenage pregnancies. I think there is something in the East African region that needs to be worked on, but we also do not know what the problem is. But there is a problem in the East African region. We can move to the next. So when it comes to the knowledge, that is how far we are doing. Family planning,